All right, welcome to another episode of On the Streets. I'm your host, Jordan Orada, and with me today is Dr. Glenda Quan, trauma surgery attending and associate residency director here at Swedish Medical Center. Thank you for being here today.
Good morning, Jordan. Thanks for having me.
We've had a lot of interesting trauma cases lately here. Lots of really sick patients, lots of limb stuff, and you have happened to be on a lot of those. We want to talk about some pearls that you have wanted to share based on some of the stuff you've seen. Does that sound right?
Yeah. So, for whatever reason, it's summertime, of course, and this is our trauma busy season. For whatever reason, it seems like we've been having a run of extremity injuries, and so we're going to talk a little bit about that today.
Perfect. I guess we'll just start with a case, or maybe we don't want to get too specific, but we can talk about a type of case that
Yeah.
illustrates one of the points that we have recently been taking care of.
Yeah, we've had a lot of pretty significant extremity injuries that have involved vascular injuries. And so we've had a couple of patients come in with tourniquets from the field. And so we can talk a little bit about management of that. And then patients' outcomes when they have vascular injuries, because, we can do a lot to try to preserve their limbs.
And I think that's such an interesting topic just because in my relatively short tenure in EMS, I've seen tourniquets go from something that we never do to something that we always do. And I think as much as they're easy to put on, there still is some misconception about how to do it right. And we still see them come in inappropriate or multiple tourniquets inappropriately put on. So I guess step one is, how do you properly apply a tourniquet? Where, how much pressure? Do you need it on a heavily oozing venous bleed? Like, give me the scoop.
Yeah. So I think we've seen, again, you're right, an increase in the frequency in which tourniquets are used for patients, and they're definitely life-saving. There have been some cases where we think that the tourniquets could have been applied better, but the gamut is it can run from not tight enough, where they're so loose that we can actually put our fingers under it, to too many tourniquets, but none of them turned down tight enough. And so there's some technique involved. I mean, the cat tourniquets are easy, and I think I love that people are getting trained in using them. But the way we like to see a tourniquet and the way they're used most effectively is as close to the injury as possible, so that you're applying pressure to arteries and veins as close to the injury as possible to preserve as much tissue proximal to the injury. So if you have an injury at the elbow, we want to see that tourniquet just above the elbow at the distal humerus. One tourniquet should be enough if it is applied properly. So I think there's some insight that we see in the operating room quite a bit when we're doing vascular surgery, or when I see my orthopedic colleagues doing operations. They will frequently use a tourniquet intraoperatively. And we use a sterile blood pressure cuff, just like you would use, in any setting, a normal blood pressure cuff. We sterilize it. We put it on the extremity. It comes with an automated machine that will turn it up to whatever amount of pressure we choose. So, for example, if you program it to be at 240 millimeters of mercury, it insufflates to that and holds it at that pressure very accurately. And when we do that, we have very reliably can get complete stoppage of flow. So we can mimic that in the field with a single properly applied tourniquet, or even a blood pressure cuff that you have on any ambulance, as long as the pressure is turned up high enough. So 200, 240, somewhere in that range should give you good stoppage of blood flow.
And really that's the key, right? Is stopping the blood flow.
That's
It's
right.
working, it's tight enough when the bleeding stops.
That's right. I think that putting the cat tourniquets on, you have to crank it down really hard. We had a case recently where we had a gentleman with an upper extremity, very deep laceration, lots of blood loss, had a couple of different tourniquets on, I think because when each tourniquet was applied, they still were not getting effective cessation of bleeding. When the patient arrived in the trauma bay, I picked the tourniquet, the cat tourniquet that was closest to the injury. I gave it 2 more full turns, and it was hard. I mean, I'm a small person, but you really have to crank it down. And then I removed the other 3 tourniquets, and the bleeding stopped.
Interesting. And because I have heard for someone, especially like a large man who's very muscly, especially maybe like on a thigh or something, it might
Yes.
take 2 tourniquets because you just can't crank one down tight enough? Or is that just I'm wimpy?
Well, Jordan, I don't know. I'm not sure that's true. A single tourniquet ought to do it
Okay.
if you turn it down hard enough. It's hard to keep cranking it down. It's helpful if the patient is not awake because it is painful. So I think there is some trepidation in turning the tourniquet down enough. But then remember, there's always the option of putting a blood pressure cuff above it and putting that pressure up beyond the patient's systolic blood pressure as a backup as well.
Okay. And so you'd said there was multiple tourniquets on this patient. Oftentimes in the field, we'll go and a bystander has used a shoelace or a belt or a piece of T-shirt or something.
Yeah.
It very acutely and appropriately tried to stop the bleeding.
Yes.
Should we take those off or leave them on?
I think that bystanders using T-shirts, shirts, belts, shoelaces, that's great. Even though you may not be able to get the blood flow to stop entirely, any slowing down of the blood flow is beneficial for the patient. So I would not discourage bystanders from using them as long as they're used, and they can always be reassessed by EMS on the scene, whether or not it's necessary, right? I think that I wouldn't necessarily advise taking tourniquets off, especially if you're in a rural, resource-limited area, because that is really going to be potentially your only method to control bleeding. But I would, rather than throwing on maybe more tourniquets, perhaps just using 1 or 2 of them, but more effectively would be my advice.
Okay. And so you also were just talking about this can be really painful.
Yes.
These patients are probably already pretty miserable. If they
For
have an
sure.
injury that they need a tourniquet, they're not happy campers. And now we're giving them more pain and discomfort. Pharmacologically, is there something that is better or worse once they get to a surgical suite? Would you rather them have ketamine or fentanyl or Versed or be totally consciously sedated if that's an option?
Yeah, I think ketamine is a great option for people like this, especially if they're also agitated for whatever reason in the field. If you are thinking of having to do a long transport, I would recommend intubating the patient for better pain control and also for crew safety, especially if you're flying a patient, for example. That's a long transport. It might just be safer to have a protected airway so that you have more options in terms of medications that you can use to control pain and agitation.
Okay. So some of our agencies locally and I know nationally don't have access to RSI, but may still have a longer transport. What's your recommendation for those? Those can be really difficult patients to manage, and that's one of those things I wish everyone could see your face because it's like, ooh, yikes, that's not good. And I think we're working toward finding better solutions, but we know that it's in a lot of areas low usage. It just creates more danger for a provider when they're not doing the skill a lot. So trying to figure out how we can manage these patients safely with the tools that we are really confident with. Any recommendations there?
Yeah, I mean, I think, fentanyl and ketamine are a good choice because you're less likely to lose your airway. I think if you can rely on a good transport crew can help you get an airway, a secured airway on a patient if at a local facility that skill is not something that's used frequently. Those are probably my recommendations, ketamine and fentanyl. But, just be careful because you can oversedate.
Absolutely. And have your BVM ready, right?
That's right.
Do any meds cause a problem once you get to the OR? Complicate with the things that you guys like to use?
No.
Okay. That's good to know. Because, I mean, ultimately in the field, we're always planning acutely, but then also thinking ahead, like what this patient this is traumatic, they need to go to an OR. I
Yeah.
don't want to do something silly that messes up what you guys are trying to do in the OR.
No, we're never critical of what EMS does in the field. We recognize that we're very privileged here at a level one trauma center to have so many options, and so many resources, so much help, and access to all of the things, all the drugs, and immediate access to an OR. We are grateful for EMS getting patients here alive, and in as good a condition as possible. So, no, there isn't anything that you can do in the field that can't be undone. And you need to do whatever you need to do to get the patient here, and for you and your crew to be safe as well.
Perfect. So we were chatting a little bit before we started recording, and I was just reminded, as you talk about technology and how pampered we are here in the hospital, about the new hybrid OR that we have here, and I know are starting to pop up in different areas. Tell me about that and how that's been beneficial for care of some of these patients with limb issues.
Yeah, we've had a couple cases where, again, we've had some extremity injuries that involve fractures of the upper and lower extremities, but also a concomitant arterial injury. So our hybrid OR room allows for a full operational suite for any type of open operation, but the patient is on a interventional radiology type bed with a C-arm attached. And so we can do any kind of endovascular case or open vascular reconstruction case. It allows them to be able to do on-table angio at the same time that the patient is getting a thoracotomy or an X-lap or an X-fix or a craniotomy even. And so it allows multiple teams to operate on the patient simultaneously to reduce OR time and try to get patients stabilized as best we can.
That sounds like we're in a futuristic movie.
It's pretty awesome.
How does that work? Like if you're doing a thoracostomy and then you have an IR physician in the other room.
Yeah, or a vascular surgeon.
Yeah, how do you guys work in concert like that?
Oh, it's great. It's actually really fun. We have colleagues that we really enjoy working with, and we consult with them frequently. We see them in the hospital, but when you're in the OR together, working to try to stabilize a patient, it's really invigorating, and it really builds those bonds that reaffirms that we really do work as teams here. It makes you really appreciate your consultants, and it's actually exciting and fun to do it together.
Nice.
There's plenty of room in the OR, and we can definitely coordinate care. Again, we had a patient recently who needed a lower extremity bypass. She had a pretty significant knee dislocation with fractures of the distal femur and also proximal tibia, but she blew out her knee with that dislocation, and in doing so, she injured her popliteal artery right at the trifurcation, which is a terrible spot. So she ended up getting a reverse saphenous vein graft from her popliteal to her posterior tibia. Then because her knee was so unstable, the orthopedic surgeons put a knee spanning X-fix on kind of at the same time. So teams are able to work side by side to get patients taken care of quickly.
That's amazing. Do you see an improvement in outcomes with these patients instead of having to go to the OR multiple times, just having it all happen kind of in one fell swoop? Does that get them out of here faster? Or
Yeah, it definitely is good when we're thinking about damage control operations, right? So patients who are in big traumas, especially if they have vascular injuries or significant orthopedic injuries, they are acidotic. They can be hypotensive. They have hemorrhagic shock. And the faster we can get them out of the operating room, where they can often be cold, losing more blood, is best. And so the quicker we can do things, the sooner we can get the patients to the ICU and continue the resuscitation.
So, as we're talking some about resuscitating these patients, I know there's been a movement amongst some of the higher performing agencies, that are FPC, flight paramedics, critical care, about carrying whole blood or plasma on their rigs. What's your take on that? And do you see that as the future of pre-hospital care, or maybe only in a subset? What do you think?
Yeah, I mean, I think there are ongoing randomized controlled trials of whole blood in the field. We're all anxiously awaiting what the results are. I think that the early data from non-randomized smaller trials have suggested that whole blood is the best, and that's what massive transfusion protocols are, attempting to recreate. It will take a culture change, especially in working with blood banks across the country, to start housing and managing whole blood, because there are some storage issues related to that. And I think that hopefully that technology will come around where we can keep whole blood around longer.
Do you think that's the biggest hurdle, is just the logistical piece of that?
I think it's twofold. I think we want to have good data to support doing that, because it will be a culture change. It'll be expensive. It's going to require a lot of education, not only in the pre-hospital setting, but in the in-hospital setting as well. When is whole blood usage appropriate in trauma patients, surgical patients, even medical patients like cirrhotics with GI bleeds? We need to have more data about what populations it's going to benefit. And then it's going to take agencies who bank the blood. There's going to be some changes that have to come with that as well.
Exciting to look forward to, though.
Yeah.
I see a glimmer in your eye.
We're all anxious to see how that plays out.
Is it because you know that that's the first step in like you being a surgeon on a helicopter and just flying around the world performing surgery in the field?
We could probably just deliver the whole blood by drone right to the field.
Why not, right?
Yeah.
If Amazon can do it, so can we.
Can land right on top of the ambulance.
That would be pretty awesome.
It's a tiny drone landing site.
My son would love that. He's all about drones right now. So aside from some issues with tourniquets, as we kind of go back to the beginning of this and some of these patients we're seeing, are there any other issues in care that you've identified from a pre-hospital standpoint? I know that you say you don't want to be critical, but we always want to know, what can we do better? You mentioned temperature in the OR. I think that is often something that's overlooked pre-hospitally, especially with trauma patients, is keeping them warm. Is that an issue acutely or not so much?
It is an issue, because once bleeding starts, right, patients get into that lethal triad of coagulopathy, being cold, and shock, and it definitely makes bleeding worse. And in the field, it's difficult, because sometimes patients are, if you're in a single vehicle accident, it might take some time before a bystander sees you. And then if it's a prolonged extrication, those patients are exposed potentially for hours before they're in a hospital setting where they can be warmed. And so anything that pre-hospital folks can do to keep that in mind is helpful, because your coagulopathy is getting worse, bleeding is worse when patients are cold.
So get them trauma naked, stop the bleeding that you can, and then rewarm.
Rewarm, that's right.
Any other things? I mean, obviously you want to find all the holes and identify, secondary survey, what am I missing? What can I correct? Any other kind of small things that are low-hanging fruit?
Yeah, I think especially, back on the topic of these more recent high-impact extremity injuries, is reducing fractures and reducing dislocations as soon as possible. We had another case recently where we had a gentleman who had a open tib fib, pretty bad, very angulated, lots of bleeding. Unfortunately, he ended up losing that leg because there was so much tissue injury, not necessarily because of the vascular issue, but he had so much muscle and soft tissue injury that he ended up losing the leg. But reducing fractures to unkink any injured vessels is helpful to try to revascularize, or at least try to return blood flow to the distal limb. And splinting, pressure dressings are great. We had another interesting case of a patient with a left upper extremity dislocation. His humeral head was anteriorly dislocated out of the glenohumeral fossa, and the head of the humerus was pinching the axillary artery just as it crossed the rim of the glenoid. And so it was hard to tell, because the patient was a very large, muscular man, and he didn't have that sort of very obvious swelling that you might have been able to identify in a thinner patient. But he had no palpable pulses in the arm. And when we did the CT angio of the arm, we saw that there had been the dislocation there. Because he was such a big muscular guy, we had a hard time reducing that dislocation, even with the orthopedic surgeons at the bedside in the trauma bay, because we knew right away that we needed some early orthopedic intervention. And it wasn't until we were in the OR with him paralyzed and completely relaxed and lots of pulling by a couple of folks in the OR were we able to reduce that injury. And so, you know, it wasn't until that was reduced that we were able to reestablish blood flow to that hand.
And how long was that hand without flow? And did that create any complications once you got flow back?
Yeah, probably several hours. He was a transport from a distance. And so he was one of those cases where there was a prolonged extrication at the scene, but then he had to be flown here. And so it had been hours, probably over 4, perhaps even close to 5 before it was reduced. Once the fracture dislocation was reduced, we got flow back in the axillary down to the distal brachial, kind of at the level just above the elbow. But again, we still did not have immediate return of flow to the hand. And it turned out that because of the kink up at the axillary, the low flow state in that artery caused clotting to occur. And so he had a big clot in the brachial. And so, again, in that hybrid IR OR suite, we were able to do an on-table thrombectomy, take that clot out, and that's actually how we got flow all the way back down to the hand. So even just reducing it can help, but it's not always going to, it might not be enough. That patient might still need a surgical intervention to return flow to the distal part of the limb.
So does that potentially create risk out of a hospital setting if someone has a pulseless arm and you're trying to make a minor adjustment to increase flow and get some pulses? If it's been that way for a while, if you did a high angle rescue and they've been out there like that for 4 hours and you're trying to do a little manipulation, should you wait? Does that create risk in moving that clot and creating another problem, or
No, because even if
try
you
to get
were to dislodge that clot distally, let's say, we can still remove that clot in the OR.
so try to get some pulses back?
Yeah, because even if you move the clot more distally, you're still getting blood flow more
Yeah.
distal to where you had been. So, we're always trying to reestablish blood flow, try to reduce any angulations or dislocations, and try to splint. We're always in favor of that.
Well, I know we only had a little time today. I don't want to take too much. I think we've covered a ton in a short period of time. Really interesting cases.
Yeah, it's been a busy summer, but yeah, lots of interesting cases. So much to learn.
Yeah, I would love to have you back another time. I know you've had a couple of kind of truncal injuries that have been interesting lately, so maybe we can do another little brief topic on that. But I really appreciate your time today. Any kind of parting words or last pearls that you want to share?
Yeah, it's been a busy summer, especially in this time of COVID. I think that patients are additionally stressed out just from their day-to-day living. And then to have a big trauma on top of that is really, I think, been really hard on our patients, more so than in other summers where we've been busy. I think that medical staff in pre-hospital and in the hospital are also additionally strained because the times where we should be becoming rejuvenated, those times are more stressful too. There's stress in the world when we're supposed to be more relaxed, and so we can return to full function when we're taking care of patients. And so I would say be kind to yourselves, be kind to your colleagues, and give our patients some leeway because I think everyone is, everyone's stressing and straining. But I am so grateful for those of us that are still here and working, and it's that collegiality and that teamwork that's going to get us through. So thanks.
Thank you. And to that point, make sure that you give yourself a break, find that time, and rejuvenate, because your patients need you to be there as much as you can be.
Be your best.
Yeah, absolutely. Thank you for your time.
Thanks,
What a
Jordan.
pleasure.
Thank you.